You can't encumber this. You can't say, we're coming to the end of this year and we're just going to put this in next year's bucket or in this year's bucket, but execute it next year. It doesn't go like that. It's important people for understand, it's like a race car, but with very well balanced tires. And you have to be responsive to those tires and keep them all in balance, or you're not going to be able to stay on the track.
If you're not at the table, you're on the menu. And you basically said, I'm tired of being on the menu and eating what everybody else has made for me. I'm going to get at the table and help design the menu.
There were people who said along the way, you'll never be able to do this. You've never served in the legislature. I'm passing 10 to 14 bills a year, and mostly that have to do with healthcare. And not because I'm, like any big rock star, because I understood the process and I know how to work with people.
We've got to get back to being rational human beings. We are smart people in general, and I'm not going to allow in 2026, I am no longer sitting in rooms with people that it's a can't attitude. It is got to be a can attitude. We can do this.
We cannot take our foot off the gas. What keeps me up at night is that if there isn't a voice, will the work continue to be done?
Well, thank you for joining us for another episode of the Leadership Lab. And I am just ecstatic today that someone is joining me who I've just recently got to know, but I am ecstatic that she is here, even though she's having to join me virtually because I couldn't get up to New Hampshire. But most people should know that you're a senator, and you're a state senator in the beautiful state of New Hampshire. And so I'm not going to call you Senator. I'm going to call you Sue, but respectfully, I can't say thank you enough for joining me. So introduce yourself to those who are listening that may not know, and then we're going to kind of get in and just start talking about all things healthcare. But Sue, give us a little bit about your story. Tell our audience your story, what your healthcare background is, how you got into being a legislator at the state level. Give us some insight into you.
I so appreciate the opportunity to be here. And although I do wish you were here with me in the great Granite State, I do love Austin. So if I could have traveled down there as well, maybe next time. So thank you again for having me today. My story, Asbel, is probably not unfamiliar to many leaders with EMS, but not within healthcare. It's not as well known. I'm from that generation of children that every Saturday night was watching Emergency and said, when I grow up, I want to be a paramedic. And that's exactly what I did. But I moved through a series of steps. So I was an EMT. I was an EMT. Now we call them advanced EMTs. And I finally became a paramedic. I've worked in the pre-hospital setting. I've worked in the hospital setting, but primarily in rural areas. And that's key because it helps to bring into focus the lens by which I do my work. But along this journey, I had the opportunity to be a state EMS director for the great state of New Hampshire. And so I sat on the other side of the table when I saw policy being made, and I was outnumbered all of the time. To the left of me, there were, a whole group of nurses, and to the right of me, a whole group of doctors, and then there'd be a whole group of firefighters, and then there would just be me. And I found that the losses were more than the wins, and I was having to implement other people's policies rather than ones that were more comprehensively linked into emergency medical services. So I started thinking a lot about that. And I'm like, well, I've heard this line out there, like if you don't like the conversation, then change it.
Oh, I love it.
So I decided to get on the other side of the table. And the first thing I did was lead locally. I ran for city council. I got a sign, and so there's 13 cities in New Hampshire, and we have a city council, and I was kind of somebody started talking to me about it, recruited me and said, you've got this interesting background, and you do the state work, and maybe you'd be a good city councilor. And so I got a sign and said, Sue Prentiss, Ward 1, and I went around and I knocked on all sorts of doors. Now, look, I didn't win the first time, but I ran again in 2 years, and I won. And I served on the city council for 12 years, and I was the mayor of the city of Lebanon for 2 of those years. And that gave me the perspective of policy from a governmental legislator side, like how you move your business along. Because I knew how to move business along on the EMS side. I knew how to move business along as being, say, a state regulator, but I didn't know the other side of it. So I changed the conversation and my seat at the table to the other side. And after working there for 12 years and having the ability to do things like negotiate a payment in lieu of taxes project that brought mobile integrated healthcare into our community being funded by a health system, some things like that. I was like, okay, um, this having this conversation from this side of the table works. So what am I gonna do next? And I wasn't quite sure, but I knew that I wanted to continue to have these conversations and continue to address gaps in healthcare and systems of care, which goes back to my rural experience, because that's where you see it the most, like these just like glaring gaps when you can link these things together and better serve people. And a state senate seat opened up. And they rarely open up where I live. It opened up. I got a bunch of phone calls, and everybody that's listening should be thinking about that when people start to call you, on average, it's 7 times that you get phone calls before you decide to run for office, and especially higher office. And so I gathered a group of people together and cobbled together a campaign, and in under 50 days, won a really competitive primary. And there were people who said along the way, "You can't." You'll never be able to do this, you've never served in the legislature. If you know how to work with people, and especially after serving on the local level, I'm passing 10 to 14 bills a year, and mostly that have to do with healthcare, and not because I'm, like any big rock star, because I understood the process, and I learned how to and I know how to work with people, and so that's what got me that's how I ended up here. Linking systems of care in healthcare, which includes emergency medical services, it's been my life's work. And everything that I do in the New Hampshire State House is through that lens all the time. I'm thinking about my time outside of the hospital. And even when I worked in the hospital, like, what does this look like? And how can I bring these people together? And so that's how I got here, and I think it's also I just like to share with folks that, my full-time job, so I'm a citizen volunteer legislator. This is not a paid position, but I'm so honored to have the role. I'm the executive director for a group called the American Trauma Society, and we work with our job is working with trauma systems and building them and helping implement them and supporting people that work in them, all about systems of care.
And I think that's important to note. I wanna for those that are listening right now, because you made a very important statement that I was looking, and I looked to my right and I looked to my left, and I'm kind of paraphrasing what you're talking about, Sue. And I looked and said, there's not really a position here. And so instead of complaining about it, what you did was saying, I'm going to get at the table because I'm tired. Somebody always told me, Asbel, if you're not at the table, you're on the menu. And you basically said, I'm tired of being on the menu and eating what everybody else has made for me. I'm going to get at the table and help design the menu. And that's what you've been doing through the process. I'm just breaking it
Exactly.
down into my vernacular from my Southern vernacular to say this makes sense to me. But if people understood that, and I think we're beginning to see that across the nation in a lot of things, and I know that your background's in rural health. And that Rural Health Stabilization Fund, I know that there is, depending upon where you are, it's controversial because of what was passed in the One Big Beautiful Bill. But the one premise that I want to focus on right now is that it's looking at innovation and adaptation in healthcare right now, something that we have got to do in healthcare. The data is clear. The costs are rising, and they're rising exponentially. And so should we be looking at things differently through a different construct, through something different? If my costs keep rising at my business and technology company that I am, and I don't do something differently, I've either got to bring in more revenue I've got to look at doing things differently. Maybe I should be adapting differently. Maybe I should be utilizing AI. Maybe there's thoughtful processes that I could be doing to try to lower my costs. And I think that's where healthcare is right now. And I remember, Sue, being at a meeting back in 2009 in Chicago when the 5 major banks held kind of a symposium with healthcare leaders talking about that what they went through. This is what happened when Dodd-Frank was passed, and it kind of did a lot
Right.
of regulation around the finance and the banking industry, that if you don't do it to yourself, the government will do it to you, and you're not probably going to like what the government does. And I know you're in the state legislature, so my first kind of question for you is, why is it really important, and what have you found that being a state senator at this level, dealing with healthcare, why it is so important the healthcare stays local at the state level? And how do we work and coordinate? It's going to be my next question for you, with the federal government to make sure that state solutions are providing that access and quality, because the patient always has to be at the forefront. And then I'll
Mhm.
get into how EMS can really help, because I think that's where innovation can really happen, by the recognition of how EMS can help in rural health. But I want you to talk to me from there, from a state legislator perspective, because oftentimes we don't get to hear your viewpoints. We hear everybody else's viewpoints. But that's why I'm so excited about this podcast, is I get to hear the viewpoint from somebody that really understands the healthcare system all the way down to that front EMS perspective.
One of the things that I learned serving locally that I did not realize, that I didn't appreciate until I served at the state level, and this will later coordinate with a federal conversation, is the closer you are to the people, the more impact that you can have, the more policy levers that you are able to pull. Being on a city council, being in in the House of Representatives in the state, or in the state Senate, we are so close to the people that we serve, that we're able to affect change that isn't always widely appreciated. Folks are, I find them largely focused on what's happening at the federal level, saying, oh, what's in respectfully, what's happening in Congress. What do people say to me, gee, why don't you run for Congress? And I'm like, no way. Like, the things that we've been able to do here in New Hampshire, and I see other states do in their state legislatures, are very powerful. And you have many of these levers at your disposal, but you have to have somebody, either you have to be there, or you have to be supporting one or more persons that are in these roles. Identify what it is that are your priorities, where are the levers, and then your elected officials will, and especially if they are people that have served as EMS professionals or within healthcare, or you have their ear, they will pull them for you. I think national associations working with state associations, and this is something that has been very powerful here, is that you need to have a 50-state strategy. I have my New Hampshire state strategy, and when I came into office, I turned to the different EMS professionals, or, organizations in the state, making up volunteers, career folks. And I said, what are the things that are important to you? And they said, well, we need better reimbursement. And we can't, we need to stabilize our EMS system. We're being crushed. We just do not have the funding we need. Our communities don't have any additional, say, tax dollars. There were, a lot of these first conversations to improve systems of care started with improving actually reimbursement. Uh, so I knew that I couldn't do anything to change Medicare. So I went and I talked to the Medicaid. I started working with the Medicaid office in the state, and I also started working with the health insurance professionals, which are they're very strong associations in all of our states, and said, okay, we can make this work better for you. But we need some, we here are some of the ideas that I have, um, and how do we make these happen? So we've been able to do things here that have been really important for the EMS system. Now, simple thing, may seem simple, but direct pay. We were still one of those states that was suffering from EMS organizations not being paid directly unless they were in network. It was a penalty, in my opinion, with respect to my, friends in the insurance industry. We we were being penalized. So these communities were being penalized for not being in network, and they were sending checks to patients. And the law said you can either send it to the patient or you can send it to the EMS professional. Well, what do you think was happening? It was going to the patients. I had communities from all over the state, not just my district, able to come down and bring an Excel spreadsheet, say, here is the variance on our books of if this money came, what's owed to us from patients that we're unable to collect from them. So we got that law changed so that ambulance services, EMS agencies that were transporting patients would be paid directly. Next thing, communities said, we're doing all these treat and no transports, which is a really important discussion. And we are doing all these treat and no transports, and it's costing us so much money as these little rural towns. Like, how do we can't survive like this? We have no reimbursement. So through that process and working with the Medicaid office and importantly the health insurance professionals, we're able to pull some policy levers around. We passed a law in New Hampshire based on the treat no transport protocol that the EMS providers work with that allows through Medicaid to be reimbursed for treat no transports as long as they meet the criteria that aligns with what these EMS professionals are by protocol supposed to be doing. And then we turned to the the insurance industry and said, "Hey, what's going on over here?" They said, "You know what? We actually have a code for this and we'll reimburse, but nobody's billing us for it." So we didn't have to change a law. We were able to change one law, the Medicaid one, and then turn to the EMS agencies and say, "You actually can get reimbursed for this." And we worked to get that message out there.
So let me ask you this while you're talking about that, not to interrupt you, because I think it's really important. What's the importance, Sue, of the unified message from healthcare industry, whether it's EMS and others, to the importance of what you're doing? So as a state legislature, from your perspective and what you know, I'm assuming people rallied around that unified message. They came to you with a unified message because many times what happens is you hear one person wants to do it this way, someone wants to do it this way, and they're trying to get on the same page to all do it together the same way for consensus. Did you run into anything like that? Do you see things like that as a state senator?
I absolutely do, Asbel. Um, it's most important when you are able to unify all the voices before you get into a room, before you introduce a bill, or even after you've introduced it. If you start to hear rumbling, you got to be paying attention and you have to unify folks. It is because your message will get lost and parties will start to separate and you won't be able to accomplish anything. And I have found that I've had to negotiate people away from their perfect scenario to say, I know this is what you want, and this group wants this, and this group wants this, but here's what we all want in common that has to do, with healthcare and, has to do with patients in our community. So can you give up this piece, and you give up that piece, and you give up that piece, and we all get this? And if we can, and we've been able to do that with very few exceptions because you have somebody, and this isn't just about me, this could be anybody, and that's why it's just so important for folks to hear this conversation. You have somebody that's sitting on that side of the table that is representing that message, that is saying that every day, and that is bringing these unified parties in, fixing this stuff again before you get in the room, and then moving it forward. And then you have to, as well, so important to watch the process. You can't for a second, like, not be watching, the folks that are involved and some of the outside influences so that if something starts to bubble up where you see maybe someone's gonna start to pull away from you, say, "Day 1, we were all in this coalition together. Now we're on day 30, and you're thinking about moving away because this is tempting. How does that impact everybody?" And being able to be a little bit like, maybe a gangster isn't a great word for it, but you've gotta, like, hold people's feet to the fire and say, "We all agree to this. And if you fracture, you break everybody apart. Stay with me."
And Sue, I think that's important. That's why I'm glad we're having this conversation, because what I see happening in healthcare in general is we allow perfect to be the enemy of good. And so I love what you said from the state senator's perspective. You're saying sometimes I have to take all the groups and say, if you want to get to something, so you're at 0 right now. You want to get to 100, but I can get you to 50. That's as good as you're going to get this go around. How can we get to 50? That means it might be a little bit painful for you, but you're at 0 now. So at least you made it 50% of the way there. And sometimes what I've noticed, even in my advocacy piece, not being on your side, is dealing with groups and others. It's almost like, well, if I don't get what I want, then just blow it up and nobody gets anything. And I think that that's where healthcare is right now in
Yeah.
general. And so we've stopped looking at it through the patient's eyes and how they perceive healthcare. And we have just said, and I'm calling it ego. Now, I'm not putting that into you, Sue. I'm going to say it myself because people know I don't have any problem with. My stand was we've got to get back to being rational human beings. We are smart people in general, and I'm not going to allow in 2026. I am no longer sitting in rooms with people that it's a can't attitude. It is got to be a can attitude. We can do this. And that might mean I've got to sit in consensus and get to a good consensus. I'm done in rooms with can'ts because there's a lot of us here that people are speaking and saying, I want to do this. And sometimes I'm not the person to be speaking with you. Maybe it's the physician that you need to be having the conversation with. They might need information that I can bring to them and I can guide them to what's needed. But maybe it's the physician community that needs to be at the table with you, or it needs to be someone that's there. So I love it. It's so important what you are saying right now. And I'm hoping people are hearing this because there's a lot of buzz, especially in our industry in EMS, around the Rural Health Stabilization Fund. And of course, I'm sure you're dealing with that right now in the legislature of how the funds are going to be spent. CMS has announced all of that. But one thing that I thought was a huge win for the EMS industry is that we actually were included in the application as getting extra credit points if they could figure out how to weave EMS into the environment. And so a lot of us are paying close attention. We're using our broad expertise in states to make it impactful because I know there's going to be a quick liftoff because states have got to be able to prove certain parameters around it or there's going to be a clawback on the funding. So there's a lot of work going on in there. So I know you guys are active in it. Can you talk about what you're doing in New Hampshire, how you're looking at that? Is that something that you can talk about? If not, I'll pivot and move to another question. But I want to see what you're doing, what you're talking. I think it would be very helpful to those that I know that are going to be listening to this and why it's so important.
So I could talk about, yeah, I could talk about what we're working on, the primary projects that have been listed for funding. And the state of New Hampshire was awarded $204 million. We got $4 million more dollars than we actually had asked for. And very early on, like the minute this was announced, and I wasn't the only one, but we've built enough of a buzz. I've just served here for 5 years, and now there's another paramedic in the state senate now, and we have EMTs in the House, and so we've really started to build a buzz, a really important buzz and conversation here about.
So you have 4 EMTs on the House side and another paramedic on the
We now have
Senate.
another paramedic in the state senate, and he's just started serving. So I've been here for 5 years. He came in last year, and in the House we have 4, maybe 5 EMTs, or advanced EMTs, that are serving. So we've been able to start to link together instead of it just being like one person here and one person there. We don't have our own particular caucus, but we have a conversation, um, ongoing all of the time. So that was really pivotal in being able to do things like, I mean, the very first thing I did when I heard this grant announcement is I called the Commissioner of Health and Human Services. New Hampshire's a small state, but what you all have to realize is whether you're Texas or you're New Hampshire, if you're not on the phone and you're not talking to people, instead of talking against them, you're not talking with them, not talking to them, you're not talking with them, and you're not listening, then you're not getting anything done. So they're gonna pick up your call. You're their constituent. I called the Commissioner of Health and Human Services and said, "Commissioner Weaver, this package, I've seen the grant guidance. We have 26 acute care hospitals in the state. 13 of them are critical access. We have serious problems moving patients in our state." I was able to list off some of the things that we had already been working on. What do we need to do to get the attention of those that are gonna be writing this grant? How do I get my fellow legislators and EMS leaders at the table? Um, One phone call. And then I went over to, and this anyone can do this. We don't have a lieutenant governor. We have, we have 5 executive counselors that are check and balance on the governor in the state, and they approve all of these contracts. In fact, they have to prove they're receiving this money into the state in order for things to happen. And I started calling them and saying, "This is gonna happen, and EMS in your area is struggling this way. Here's the person you can talk to. How do we get involved?" So it was alerting everybody, like, don't talk against it. Don't sit back and wait for someone else to do it. And you don't have to carry the entire ball, Asbel, but you have to start the conversation. So that was the first thing that happened. And from there, we have 9 different projects that are on the list, that have ultimately been funded that relate to or are directly about emergency medical services, and they are currently being prioritized. And I'd love to talk about those, but before I do, I want to touch on your piece about this liftoff and the potential for clawback. I have to say that, going back to the Bush administration and then when I worked in state government there, I do remember being involved in some grant writing where there were benchmarks and it was outcome driven, and there were reporting requirements that hadn't been there previously, and states had to make, like, right off, like right out of the gate, or you couldn't go anywhere. So there's some precedent that's been set. But what's different about this is how quickly the money comes to your state, how quickly you have to, like, implement it. You can't, and start, like, reporting and showing your progress. And unlike other grants, if you can't encumber this, you can't say, "Well, we're coming to the end of this year, and we're just gonna, like, put this in this next year's bucket, or in this year's bucket, but execute it next year." Doesn't go like that. I think you know this, but it's important people for understand, like, this is it's like I don't know, or like a race car, but with very well-balanced tires, and you have to be responsive to those tires and keep them all in balance, or you're not gonna be able to stay on the track. Um, we were talking about this I'm on the Senate Health and Human Services Committee today, and we were talking about another piece of the Rural Health Transformation Program that we're dealing with in New Hampshire then, and about the claw, like, if you don't comply, you don't do these things, then this money there will be pullback, there will be penalties. So everybody's on board with keeping this this race car really balanced on the track.
And I think it's important for people to hear right now what you just said. And I love your story about the analogy of the race car and making sure they're very balanced, because it has to be quick. So if you have an idea in EMS that you're like, it's going to take 18 months to show that result, that is not for this time right now. You need to be finding those quick wins. And that's what we are coaching. There's several of us right now on the national level, Sue, that we're beginning to rally together some of the data companies, because data is going to be very key and pivotal. We need longitudinal records. So there's individual great companies like ESO and others that have longitudinal data that is going to be able
Mhm.
to provide states with, this is the impact that we know can have very short and quick. So don't get tied up into like, well, we can do this, we can do that, because sometimes the EMS industry will just run amok about pie in the sky stuff. And I'm not saying it like derogatory. I'm just saying you've got to focus. So what you just said right now, and just so folks know, we did not script this. I had no idea that Sue was going to say this. I'm telling you, we are reading each other's mind. You could not have said it better, and it came from your voice to be very careful, because this is moving rapidly and quickly. So to that end, and then I'm going to pivot and have the one thing where you and I really got to know each other a lot on, and this was around the No Surprise Act stuff. But we're going to leave that to the very end because I have one more question that I want to talk about rural health, because that's where people are really talking, because I want to get it in the mind of our industry, because we have a pivotal point to really show and demonstrate some things that if we can make this happen in the Rural Health Stabilization Fund, this is our launching pad
Yes.
for national payment reform policy. And we talked a lot about this in some of our recommendations or findings when we did the No Surprises Act. And you were a big part of really speaking from that legislator's perspective, as others were as well. But talk to me if there's any dialogue happening, what you're looking about that from the integration of one of the pieces that EMS can help. Is it transferring? Is it providing some different aspects in some of the rural areas of New Hampshire, critical access hospital connection? Tell me a little bit about what you're thinking, what you guys are thinking about right now, right out of the gate.
This episode is sponsored by Solutions Group Services, healthcare leaders' go-to source for maximizing reimbursement and inspiring innovation. At Solutions Group Services, our technology and consulting expertise help organizations recover millions in hidden revenue without disrupting their workflow. Through our flagship AI-powered tech product, Black Ink, we reveal the dollars stuck in insurance claims and give you the map to get them back. Because for healthcare leaders, they know leaving money on the table isn't an option for their organization. Learn more at solutionsgroup.com and discoverblackink.com.
So, Asbel, it is like, we did not script this, but we are so on the same page. And I consider any of the projects that are, have been identified for funding in this already had some level of legs to them. And goes back to one of my favorite books, The Tipping Point by Malcolm Gladwell. These are things that are already within the margin. It's not about low-hanging fruit. It's things that are within that margin that you don't have to, they're super important. You can make them happen, and you don't have to build some entirely new initiative. It's like we overlook these things that are already out there that we can turn around. And turning these around quickly and keeping the balanced tires is so important. So some of the things that we've been talking about in New Hampshire, and when I made those, I talked about those calls to the commissioner and to executive counselors. I was also talking to this members of the State EMS Association and the Ambulance Association and the state Medicaid office, anybody that I could. What I knew and what I know that's so important is that we can't get patients from one hospital, an outlying, excellent critical access hospital. We can't get them to tertiary care because, over the years of under reimbursing, we have just seen the system deteriorate. And so we have patients that are waiting to be moved that, if a helicopter can't fly, they're not going anywhere. And sometimes it's days. And this is, we're a rural state, but we're not as rural as some other states. So it has been very, we have not had any tragedies, but it has been incredibly eye-opening to other policymakers to hear these stories and to want to take action on them. So I'm going to give you an example and then talk about some of the things that we're doing. I got a letter from a locum, a visiting doc who was up in providing obstetrical care in one of the most northern corners of New Hampshire. And she had heard about some work I'd done in maternal health care and knew that I was an EMT. And she sent me a letter and said, I had a 32-week pregnant woman who was, experiencing complications. She was bordering on instability. She needed to be with high risk obstetrics. It took us 2 days to get her moved. We had no local availability, and eventually an ambulance had to come from this tertiary care center almost 2 hours away, which is in my backyard, the Dartmouth Hitchcock Medical Center, and come and get this mom and bring her down so that she could be safely managed and delivered. I mean, there's, a real life story to bring to other policymakers, and so that, to bring to them to help them to understand so that they'll take action. So one of the biggest areas that we're focusing on is transportation. So some of it is about workforce, and some of it is about equipment, including vehicles and regionalization. And that's something that folks don't always like to hear about, but it's within the tipping point. Look, we have educational programs that are happening. We have vehicles that are out there, but we can't necessarily get them staffed all of the time. And we have all these strategic locations, but empty buildings, because there's nobody there to staff them. So we've been focusing on those areas. And there's one other area in terms of mobile integrated health that's innovative that I think it's important to touch on. But I've been really I've been a big proponent, and this is what was important, not just for me, but for everybody involved to make sure that we had a way to get people trained or keep the people that are trained, help them elevate their level of training, both inside and outside the hospital, that we could share vehicles, staff, basically work towards a more regional model. People don't always want to give up their identity, but you can't get things done unless you're willing to remember that place of 50%. You got to go 50% here. Like, you're going to have to give up something if it's most important to move people forward. And then, there's the staffing piece, so workforce, there's the equipment piece, and there's moving towards more regional models. And it doesn't mean you have to build a whole new service. You can look at all these services that already exist and say, how do we bring you all together? How do we incentivize that? I call EMS champion program, and that where there's one anchor and others come together around that, and you can make a system, not make them, but you can support them in moving these patients efficiently to where they need to go.
Ooh, I did not interrupt you for a reason, because I wanted to make sure that people heard this. And I'm going to make a short out of it, and we're going to make reels, and we're going to get this out because the industry needs to hear what you just said. So you may not get, because I'm hearing lots of things. Well, we want this, we want that. They're trying to work. And I'm like thinking, this has got to be quick liftoff. And you've got to have that well balanced. I'm going to give you, Senator, credit for that. But I love your analogy of the race car and the balancing of the wheels. And this has to go fast. And you've got to get to that. You just gave the industry several things for them to really think about as a state legislature as you're working through this. Wow. Amazing. Perfect. I literally, and I'm telling you folks, we did not script this. I had no idea what you were going to say, but that is what our industry needs to hear. It may not be what we want to hear, but it is what we need to hear in order to make this so there's not a clawback, and that this becomes over the next year, 2, 3, 4 years that you're proving that you're helping with access issues, and we're meeting those initiatives that this administration wants to meet through that Rural Health Stabilization Fund. And I love too, Sue, that while there's a lot of different ideas about the Rural Health Stabilization Fund and the merits of it and what that happens, that it sounds to me like you guys are just saying, you know what, I'm not letting politics blind me through this process. I'm just going to pick up and we're going to figure this issue and get that done and what's the best for individuals that live in our state in New Hampshire as well. So I'm going to pivot really quick because you've been so gracious to give me some of your time here, and it's probably going to dovetail in with what you're doing with rural health, but I want to talk about how we met for the first time. And that was through your active work on the Ground Ambulance and Patient Billing Advisory Committee, representing one of the stakeholder groups in the legislative function. And you were assigned and picked by the administration at the time to be on the committee that I was honored to be able to chair. And just working through all of the dynamic personalities and ideas, it was amazing how we came to consensus on things. It was literally, I was amazed that working with payers and academia and the different stakeholders from labor to Treasury to the Centers for Medicare, or HHS at the time. But there was a lot of things that happened. And so I want to talk through that. We made some recommendations to Congress. There still is things that you hear out there that the ambulance industry's in the news anecdotally for a lot of things sometimes of people still getting what they call a surprise bill. And I'm not here to get through that piece of it, but tell me what you think about the recommendation from your position there. Should there be a federal solution pursued, or should we just let the states manage this process and work to how we pass something federally to move that to it? Where are you at on that? I know it's been a while since we've done this. There's still a lot of discussion. I think we're 16, I think about 18 states. 16 states, I think, have passed some stuff, and then we still have a few states out there that are still working through the piece of it to address, but it still doesn't address everything. But where are you at on that?
I learned more about reimbursement than I ever thought I would by from different perspectives, um, different stakeholders during that process. And I, it has informed the way that we have been able to manage no surprise billing here in New Hampshire, as well as system stabilization. And I think our state is one that serves as a model for other states in developing solutions around at a state level to, end balance billing and to bring, basically increase reimbursement rates and bring stabilization to these systems that have been struggling, recognizing that this doesn't all have to be done at the federal level. So I as part of that program or that project, what I recognized was, the commitment to, I appreciated that Congress said, EMS is so different than the way healthcare is done in every other corner. We're going to segue this out. And we're going to let these different industry professionals, not just from EMS, but, from the insurance industry and regulators and patient advocates come together and sort through this. Done in a very organized, cohesive manner with a lot of give and take, but it was clear to me that everybody was committed to taking patients out of the middle, okay? And everybody was committed to taking the EMS providers out of the middle, and by doing that, we were able to move leaps and bounds, and I just wanna bring this forward and then, segue into or, pivot to how we did this here in New Hampshire and what I think the future of this is. You know, it was clear to me, we made that recommendation right off the bat that we don't think that patients should receive a balanced bill. And we made recommendations, for Congress to enact. But at the same time, it didn't stop anybody who was either already doing this or going to do this in their states from getting the work done. So that if, and this is my 50 state strategy, if you already have this in place, like take a page out of the book that's already been written, okay? If you already have this in place, then take these policy recommendations and make them happen. And one of the key parts of this through the process was that everybody recognized that like say, rate setting when we started to talk about like what reimbursement should look like is really determined in a public venue, by local policymakers. And many times, if not every time, somebody's got to raise their hand from who's representing a member of the public from a local city council or a select board and say, yes, that's what this should be. We had to get right down to the root of that to be able to move through it. So all of this to say, we can sit and wait for the federal government to do this. All of that work that was done was fabulous, but we're still sitting and waiting. So if states, and you just recognize that we're up to 18 states, and I think New Hampshire was maybe number 14, and we were the first in New England to really do a really comprehensive package, which we're incredibly proud of. But there's a playbook that's already written, a playbook that, again, takes patients and providers out of the middle, that can stabilize your system, can improve reimbursement, recognize who's actually, making this policy, and move forward to make it happen. And if the federal government ever gets to it, that's great. But let's not knock out any of the work that's been done. So that's, I think when we start to talk about what can be done at the state level and what can be done at the federal level, and we talk about this particular, the gap back, the ground ambulance patient billing committee work, you can say, look, a lot of great work was done. states like New Hampshire and others have taken this work, gotten these policies passed. If it ever passes on the federal level, great, because states that can't get it done or don't have it covered, there's their option. But for those of us that do, let us keep doing what we're doing, because if you're smart in how you do it, you're gonna lean back on those recommendations so it's all covered.
And I think it's important what you just brought up here too, that people that are listening is it was very important to understand that states and local, they know what is needed for their patients in the EMS sector. And that's what got back unanimously recommended to Congress to pay attention to that. And so you're right on point if people are listening from your viewpoint. I mean, this is not from while you have industry background or whatever, you've been a state legislator for a while now and you understand the importance of that and what that looks like, because local healthcare truly is local. And there are parameters that are put into place from GATBAC that gives those parameters to make sure there's no fraudulent waste and abuse. I know that's a big deal that people are looking at right now, but those recommendations are important to there. So I've got one thing I want to ask you.
Okay.
And put on your healthcare lens, whatever, is what keeps Sue up at night related to healthcare? What's one thing that you're like, this keeps me up at night?
It's a great question. And I have two things that I want to say. But the first thing is that even with all of the work that we have done and are doing to link EMS EMS is part of healthcare. I mean, we're really unique. We're at the intersection of public health, health and healthcare, and public safety. We cannot take our foot off the gas. What I worry about is that somebody will stop watching the shop. And I'm not just talking about myself. I mean, we have a real focus on this now. I think it's legacy type work, and that we're going to be institutionalized in policy the way that I talked about, looking to the left and seeing the nurses and looking to the right and doctors. Like, that has to be in place, because what keeps me up at night is that if there isn't a voice, will the work continue to be done? And building these policies and our presence, Asbel, in a way where we are never forgotten, even if there isn't an EMT or a paramedic sitting in one of these seats, will continue to go on. We will always be known. And when a policymaker is looking at a grant program, they won't say, "Oh, I'm looking for Sue or Asbel," or they'll say, "We need to make sure we involve emergency medical services in this, in this entire healthcare conversation. We can't get lost." That keeps me up at night. Here's how I know it's still an issue: is that when I was recently at a meeting and I'm sitting in the front row, and the commissioner of safety that oversees emergency medical services, looking right at me and says, "We have just so many great firefighters and police officers out there doing this work." And we do, but they didn't say EMS. They didn't talk about healthcare. This had to do with highway safety. So what keeps me up at night is that our voice could be lost, and we have to build these things in a way that's institutionalized and sustainable, like that there is that institutional memory that is going to pull this through regardless of who sits in these chairs. And I think it should be everybody's job throughout this nation that serves within healthcare and the emergency medical services part of healthcare, because it's part of the system, that they make sure that their governors, their legislators, their city councilors say, fire, police, EMS. EMS, fire, police. We make sure that all three of those things are said all of the time. Okay.
Sue, I'm going to just end it right
And now I'm
there.
dark. It's nighttime.
It's nighttime. I see that it's getting night for you. So we were able to watch you, and she's at the state capitol right now in the legislative office or whatever. So I can't imagine. She's been doing work, healthcare work before you got here. And
All day.
so thankfully she was able to give me some of her time so we would make it work, whatever, because you said some very key points that don't get lost. And I learned some things about New Hampshire today that I did not know. And that was that you guys have really had an active, I'm not saying campaign, but an active education to get people that were EMTs in the legislature, to get more paramedics and EMS on the Senate side, because that is going to help with getting that institutional knowledge there. I'm starting to hear other states are doing that, where it's more EMS starting to come in. They're starting to take active role in getting involved in the process, so they're at the table and not on the menu, and helping to design what the menu
Exactly.
looks like that will help the patients that they serve in their communities. So, Sue, I can't say thank you enough for doing that. Thank you for being a public servant, and you're a volunteer public servant that is also doing great work in trauma. And so thank you for taking the time during this critical time to spend 50 minutes or so with me on this podcast today.
As I said at the start, and I appreciate the opportunity, Asbel. I mean, it's been wonderful. It has been, and and it has been wonderful to work with you on the Gap Back initiative. All that I learned there, and that we've been able to stay connected. And I want you to know that um, I have made it a point uh, to everywhere I can to talk about running for office for EMTs and paramedics, going to meetings and saying, including at other conferences, going on and saying, you got to run for something. It is my mission to make sure that every state legislature has one or more EMTs, or an advanced EMT or a paramedic in it, not on the menu, but running or being part of that policy conversation. And I won't sleep until that's done.
I can't say thank you enough. And if anything that I can do to help, I'm going to do that on a national front to get your message out there, and get you speaking that message, because it's very important coming from your mouth. So thank you so much. Thank you for joining me here on the Leadership Lab, Senator.
I'm gonna go turn some lights on. Thank you for having me at the Leadership Lab today, Asbel. Hola to Austin, Texas.
Hey,
Bye-bye from
next
New
time you'll
Hampshire.
be down here with me.
Absolutely, love to.